Imagine a structural defect of just 2 millimeters. I mean, in a bridge or a skyscraper, a 2 millimeter deviation might be considered, just a rounding error, easily absorbed by the surrounding concrete and steel.
Right, it wouldn't even register.
Exactly. But in the human wrist, a 2 millimeter shortening of the ulnar bone violently shifts the entire biomechanical force of your hand. It dramatically reroutes the load, literally choking the blood supply out of the tiny bones next to it until they just, well, crumble.
It's brutal physics.
It really is. Today, we are looking at the brutal mathematics of the ulnar wrist. Welcome to this highly focused deep dive. If you are preparing for your trauma and orthopedics fellowship exams, whether that's, the DNB Orth, the MRCS, or the EBOT, we are here to be your study companions while you drive or do some chores. Our mission today is mastering the ulnar side of the wrist and the far end of the radius.
And, it is a phenomenal anatomical zone to study, largely because it is just completely unforgiving. The theme of this area, and really the reason it's tested so heavily, centers on three core functions. It's about cushioning, it's about rotation, and it is about load sharing.
Cushioning, rotation, and load sharing.
Right. Everything we discussed today, from dying carpal bones to ligament tears, stems from a failure in, well, one of those three functions.
Okay, so to fully explore those mechanics, we're going to follow two main protagonists. First, the lunate bone and the insidious pathology that causes it to structurally fail, which is Kienböck's disease. And second, the soft tissue shock absorber sitting right beneath it, the triangular fibrocartilage complex, or the TFCC.
Let's start with the bone itself.
Yeah, let's look closely at the lunate in peril.
So the clinical definition of Kienböck's disease is avascular necrosis, or AVN, of the lunate. Functionally, this means the intraosseous blood supply to the bone is compromised.
It just loses its blood flow.
Exactly. The bone marrow becomes ischemic, the trabeculae undergo microfractures, the bone softens, and ultimately, the entire architecture of the lunate just collapses under the daily weight of the hand.
So the absolute key takeaway here for the exam is the etiology. I mean, Kienböck's is a vascular necrosis of the lunate. But this ischemia, it doesn't usually happen because of a massive single traumatic event like a dislocation, right? It's a progressive multifactorial disease.
Highly multifactorial, yeah. You have to consider the vascular anatomy first.
Mm.
The lunate receives its blood supply from a network of dorsal and volar radiocarpal vessels.
Right.
But inside the bone itself, the vascular pattern varies wildly among individuals. Some have this really robust Y pattern, while others have a very precarious single I pattern of vessels, leaving the bone intrinsically vulnerable to ischemia.
Okay, so biology plays a part.
It does. Add in repetitive microtrauma from daily labor, and the bone is already on a knife edge. But the major anatomical risk factor, and this is the absolute classic exam trap, is its association with negative ulnar variance.
Negative ulnar variance.
Right, which simply means a short ulna. There is a minor association with reduced radial inclination, but negative ulnar variance is the absolute key to remember.
Wait, I gotta say, I struggle with the logic here. I want to make sure we truly understand the physics of this for the listener. If you have a short ulna negative ulnar variance, wouldn't that physically create more empty space on the ulnar side of the wrist?
You'd think so, right?
Yeah, and shouldn't more space mean less compressive pressure on the carpal bones?
It is incredibly counterintuitive until you look at the wrist as a weight-bearing pedestal. Think of the lunate as a keystone resting across a wide, flat pedestal.
Okay, I'm visualizing it.
That pedestal is formed jointly by the distal radius and the distal ulna. In a normal wrist, the lunate sits perfectly balanced across both. Now, if the ulna is short, that negative variance, the ulnar half of the pedestal literally just drops away. The lunate completely loses its foundational support on the ulnar side.
Oh, wow. So instead of floating comfortably in that extra space, the lunate is essentially hanging off a ledge.
Precisely. It doesn't relieve pressure, it catastrophically concentrates it. Because the hand is still driving force downward, the lunate is now being violently sheared against the hard remaining edge of the radius, the radiolunate facet.
Right, because there's nowhere else for the force to go.
Exactly. That short ulna dramatically increases the point loading force on the radial side of the lunate. It creates massive focal stress, leading to those trabecular microfractures, which then interrupt the already fragile interosseous blood vessels, leading to the avascular necrosis.
That paints a very clear mechanical picture. The foundation falls away, and the bone is basically sheared to death against the radius. Because this is so heavily tested, we need to make sure this is locked in. Let's state it twice. Kienböck's disease is intrinsically linked to negative ulnar variance, meaning a short ulna.
Yes, repeating that crucial link. Kienböck's disease is intrinsically linked to negative ulnar variance, meaning a short ulna. If you see a short ulna on the film, you should immediately be thinking of that negative variance driving a vascular necrosis of the lunate.
And clinically, who is the patient walking into the exam room with this?
The classic presentation is a young adult, typically between 20 and 40 years old, very often a manual laborer. They will present with insidious progressive dorsal wrist pain.
So no obvious acute injury.
Usually no. They'll have stiffness, a noticeable reduction in grip strength, and localized swelling directly over the radiocarpal joint. They might report a history of some vague, minor trauma months ago, but almost never an acute event that would fracture a healthy bone. It's the repetitive loading over a short ulna that finally pushes the bone into necrosis.
Got it. So to close this section, if you only remember one thing, remember this. Kienböck's disease is defined as a vascular necrosis of the lunate, and it is intrinsically associated with negative ulnar variance, which is a short ulna.
Perfect. Now that we understand the biomechanical forces driving the lunate into ischemia, we have to track its physical destruction over time. This brings us to the Lichtman staging system. This ladder dictates exactly how we measure the collapse.
The Lichtman ladder. This isn't just academic trivia, right? This staging is the absolute through line that will dictate your surgical treatment plan.
Absolutely.
We need to walk up this ladder meticulously, from stage I to stage 2.
Let's start with stage I. This is the pre-collapse, purely vascular phase.
Yeah.
If you take standard plain film x-rays of a stage I wrist, the lunate looks completely normal.
Wait, normal?
Normal. The architecture is intact. You make the diagnosis of stage I using an MRI. The MRI will show diffuse edema within the lunate specifically, a decreased signal intensity on T1 weighted images, and an increased signal on T2.
Ah.
Okay, this proves the blood supply is compromised and the bone marrow is reacting, even though the calcium structure hasn't failed yet.
So the defining feature for stage I is normal plain films, but edema and loss signal visible on MRI.
Correct. Stage 2 is the point where the pathology finally becomes visible on a standard plain film x-ray. The bone is actively dying, and the body is attempting to heal it.
What does that look like?
You will see definite sclerosis, a noticeable density change in the lunate. It looks much whiter and harder on the x-ray compared to the neighboring scaphoid or trichotrum. This happens because of new bone deposition on dead trabeculae during attempted creeping substitution.
But the shape is still okay.
Yes, that is the crucial discriminator for stage 2. The lunate preserves its normal shape and its normal height. It's sick, it's dense, but it hasn't structurally buckled.
So stage 2 gives us sclerosis on the plain film, but the shape and height of the lunate are fully preserved. That brings us to stage 3, which has to be where the dead bone finally buckles under the load.
Stage 3 is the structural failure. The lunate collapses. It fragments, it loses height, and it flattens out. But this is the ultimate trap for the fellowship exams, because stage 3 is split into two very distinct biomechanical subcategories, 3 and the thing 3.
Okay, listener, perk your ears up for this trap.
The discriminator here isn't what is happening to the lunate. The lunate is collapsed in both. The discriminator is what happens to the neighboring scaphoid bone.
We need to unpack the carpal kinematics here. The proximal row of carpal bones, the scaphoid, the lunate, and the trichotrum, they operate like a linked chain, right? They don't have tendons inserting directly onto them.
Right, their movement is dictated entirely by the mechanical pressure around them and the ligaments binding them together. That intercalated segment concept is vital.
How does that work normally?
Normally, the scaphoid naturally wants to flex forward, and the trichotrum naturally wants to extend backward. The lunate sits in the middle, tightly bound to both by strong ligaments, acting as the stabilizing tug-of-war rope that keeps them all balanced in neutral alignment.
Okay, so I'm thinking of a structural analogy here. It's like a row of buildings. In stage 3, the lunate building collapses, it flattens out, but those interosseous ligaments hold. The neighboring building, the scaphoid, stays upright and normally aligned.
Exactly, the collapse is contained. Stage 3 is lunate collapse without fixed scaphoid rotation. The overall carpal height might drop slightly, but the structural ring of the wrist remains relatively stable.
And what about IB?
Stage 3 is a totally different biomechanical disaster.
Yeah.
In WIBE, the collapse drags the neighboring building down. The lunate collapses so severely, or the ligaments attenuate so much, that it can no longer hold the scaphoid back. The lunate drops, and it drags the scaphoid down into a fixed, flexed rotation, radically shifting the load.
You get lunate collapse with fixed scaphoid flexion. And how is that measured radiographically? What's the numerical threshold for that flexion?
We measure the radioscaphoid angle on a lateral X-ray. In stage 5, you will see a radioscaphoid angle of over 60 degrees.
Over 60 degrees.
Yes. This creates a classic disci deformity, a dorsal intercalated segment instability. The scaphoid is pointing sharply downward, the lunate is a flattened disc, and the normal load-bearing pathways of the wrist are completely destroyed.
That makes the 5 versus I5 split so much more logical. It's the difference between a localized bone collapse and a collapse that rips the entire biomechanical chain apart.
Which accelerates the wear on all the surrounding cartilage, inevitably leading us to stage 3. Stage 3 is the end-stage condition. You have this severe lunate collapse, but now you also have generalized pancarpal arthritis. The joints between the radius and the scaphoid and the capitate. They all narrow, develop osteophytes, and become heavily arthritic.
The entire carpus is degenerate. We need to cement these stages firmly in mind before we move to treatments. We will state the full Lichtman progression twice. Listen closely. Stage 1 is normal plain films with MRI edema. Stage 2 is plain film sclerosis with preserved shape. Stage 3 is collapse. Stage 4 is collapse with generalized pancarpal arthritis.
Reviewing the primary stages again. Stage 1 is normal plain films with MRI edema. Stage 2 is plain film sclerosis with preserved shape. Stage 3 is collapse. Stage 4 is collapse with generalized pancarpal arthritis.
And now that highly tested stage 3 discriminator twice. Stage 3 is collapse without fixed scaphoid rotation. Stage 3 is collapse with fixed scaphoid flexion, defined as a radioscaphoid angle over 60 degrees.
Reinforcing that crucial split. Stage 3 is collapse without fixed scaphoid rotation. Stage 3 is collapse with fixed scaphoid flexion, defined as a radioscaphoid angle over 60 degrees.
So if you only remember one thing from this section, remember this. The Lichtman ladder tracks Kienböck's from MRI edema in stage 1 to sclerosis in stage 2 to collapse in stage 3, where I3 lacks scaphoid rotation and I5 features fixed scaphoid flexion over 60 degrees, ending in pancarpal arthritis in stage 4.
Right. Having established that roadmap of destruction, the through line naturally leads us to how we intervene. The staging directly dictates our surgical decision-making.
The treatment escalation.
Yes. The overarching philosophy of the treatment ladder is a logical progression. Immobilize, then unload, then salvage.
Immobilize, unload, salvage. Let's map those 3 distinct philosophies directly onto our Lichtman stages.
In stage 1, the bone is inflamed and the blood supply is tenuous, but there is no structural damage. The treatment here is conservative. Immobilization. You put the patient in a cast or a rigid splint for several months, use NSAIDs, and give the body a chance to spontaneously revascularize the lunate without surgical trauma.
Moving up the ladder, what if they present in stage 2 where the bone is sclerotic, or stage 3 where the lunate has just started to collapse but the scaphoid is still holding its normal position?
At stage 2 and stage 3, the lunate still has a somewhat usable shape, and the broader carpal kinematics haven't entirely failed. So your goal transitions to joint preservation. You need to unload the lunate and actively try to revascularize.
Unload it how?
You want to definitively take the physical pressure off that dying bone. Remember that key risk factor, the negative ulnar variance. This is where you fix it. You perform a joint leveling procedure, specifically a radial shortening osteotomy.
This is where we cut the radius, right? Even though the ulna is the short bone, we cut a wedge out of the healthy, longer radius, compress the 2 ends together with a plate, and artificially shorten the radius to match the short ulna.
Exactly. Leveling the pedestal. By shortening the radius, you drastically redistribute the compressive force away from the lunate and shift it toward the ulnar side of the wrist.
What if their ulna is normal?
If the patient happens to have neutral ulnar variance but still has Kienböck's, you might do a capitate shortening or a vascularized bone graft to bring a fresh blood supply directly into the lunate.
But unloading is the mechanical goal for 2 of out.
But what happens when we hit that catastrophic stage 3? The lunate is flattened, the ligaments have failed, and the scaphoid is pitched forward in fixed flexion past 60 degrees.
In stage 3, unloading won't work anymore. Because the scaphoid is fixed and flexed, unloading fails. The carpal kinematics are irreversibly destroyed. If you shorten the radius now, you still have a flexed, malaligned scaphoid grinding away the articular cartilage.
So you have to abandon joint preservation. Right, you move to salvage procedures. For IHIB, this usually means a proximal row carpectomy, or PRC, where you simply excise the scaphoid, lunate, and trichentrum entirely, allowing the capitate to articulate directly with the lunate fossa of the radius.
Or you lock the bones together with fusions, right?
Limited intercarpal fusions. You might perform an STT fusion fusing the scaphoid trapezium and trapezoid to hold that flexed scaphoid upright, or scaphocapitate fusion. Or, in some specific cases, you just do an isolated lunate excision and let the wrist settle.
And for stage 4, the entire joint is filled with osteophytes, the cartilage is gone, and the patient has a completely stiff, agonizingly painful wrist.
If you have a stiff, disabled stage 4 wrist, those motion-preserving salvage options like a PRC will fail because the capitate cartilage is already destroyed. The definitive answer, the absolute gold standard for a destroyed stage 4 wrist, is a total wrist arthrodesis.
Just fusing the whole thing.
You use a specialized dorsal plate to fuse the radius, the carpal bones, and the third metacarpal into one solid block of bone. You trade all wrist motion for a stable, strong, and completely pain-free grip.
Okay, before we leave the Kienböck's treatments, there is an early intervention highlight we must cover. It's a procedure called distal radius core decompression. And I want to pause here because intuitively this sounds completely backwards.
It does sound odd at first.
Yeah, I mean, if the lunate is dying from a lack of blood, how does drilling a completely different bone, the radius, help rescue the dying lunate?
It is a brilliant physiological trick. Core decompression of the distal radius is used as an early, pre-collapse joint-preserving option for stage 1 or early stage 2. The surgeon makes a small incision, passes a drill bit or a curette into the metaphysis of the distal radius, and purposefully creates controlled trauma within the healthy marrow space.
Okay, why?
The mechanism behind this is the regional acceleratory phenomenon, or RAP.
So by damaging the radius, you provoke a massive systemic healing response.
A localized, intense vascular healing cascade. By creating surgical trauma in the highly vascular radius, it incites severe regional hyperemia, a massive, localized increase in blood flow. This hyperemic response doesn't respect bone boundaries.
It crosses over.
Exactly. The increased blood flow crosses the radiocarpal capsule and floods the neighboring lunate, helping to revascularize and rescue the struggling bone before it structurally buckles.
That is fascinating biology. We need to lock this treatment ladder into our memory banks. We will state the steps twice. Stage I relies on immobilization. Stage 2 and Stage 3 rely on unloading and revascularizing. Stage 3 and Stage 4 move to salvage procedures.
Tracing the surgical progression a second time. Stage I relies on immobilization. Stage 2 and Stage 3 rely on unloading and revascularizing. Stage 3 and Stage 3 move to salvage procedures.
If you only remember one thing from this section, remember this. The Kienböck's treatment ladder is immobilized for Stage 1, unload and revascularize for Stage 2 and 3, and perform salvage procedures for Stage 3 and 4.
We have covered a tremendous amount of dense, highly testable material. This brings us to a crucial point for consolidation. Let's make sure the mechanics of the lunate are completely solid before we shift our attention to the soft tissues.
Absolutely. If you are driving right now or you're scrubbing in, this is the moment to focus. We are doing our first mid-episode recap. We will rapidly summarize the etiology, the staging, and the treatments we just discussed. And to ensure you retain it for the exam, we will adhere to our rule and state every list and discriminator twice during this recap.
First, the core etiology. Kienböck's disease is a vascular necrosis of the lunate, intimately linked to negative ulnar variance, which is a short ulna. Stating again, Kienböck's disease is a vascular necrosis of the lunate, intimately linked to negative ulnar variance, which is a short ulna.
Next, the Lichtman staging list. Stage 1 is normal plain films with MRI edema. Stage 2 is plain film sclerosis with preserved shape. Stage 3 is collapse. Stage 4 is collapse with generalized pancarpal arthritis. And again, Stage 1 is normal plain films with MRI edema. Stage 2 is plain film sclerosis with preserved shape. Stage 3 is collapse. Stage 4 is collapse with generalized pancarpal arthritis.
Yeah, that vital Stage 3 discriminator. Stage 3 is collapse without fixed scaphoid rotation. Stage 3 is collapse with fixed scaphoid flexion, meaning a radioscaphoid angle over 60 degrees. Stating again, Stage 3 is collapse without fixed scaphoid rotation. Stage 3 is collapse with fixed scaphoid flexion, meaning a radioscaphoid angle over 60 degrees.
Finally, the surgical treatment ladder. Stage I relies on immobilization. Stage 2 and Stage 3 rely on unloading and revascularizing. Stage 3 and Stage 3 move to salvage procedures. And again, Stage I relies on immobilization. Stage 2 and Stage 3 rely on unloading and revascularizing. Stage 3 and Stage 4 move to salvage procedures.
Excellent. Now, we can logically transition our focus. We've seen how negative variance in bone length can physically destroy the lunate.
Right.
But the lunate doesn't sit in a vacuum, you know. It is resting directly on top of a massive soft tissue shock absorber.
Yeah.
If the bones above are transferring all this force, we need to understand the anatomy absorbing it below. We are deconstructing the TFCC.
The trianguli fiber cartilage complex, the great ulnar cushion. When we open up the ulnar side of the wrist, what exactly are we looking at? What are the anatomical components?
It is a dense, multi-layered hammock of tissue. There are exactly 6 anatomical components you must memorize for the exams.
6 of them.
Yes, they are. The articular disc, the dorsal radial ligament, the palmar radiolunnar ligament, the meniscus homologue, the ulnolan ligament, the ulnotricutal ligament.
Wow. Okay, keep going.
And finally, the ECU subsheath, the extensor carpi ulnaris subsheath.
That is quite the anatomical grocery list. But before we commit it to memory, we need to highlight a massive exam trap here. The examiners love to present a multiple choice question asking you to identify the structure that is not part of the TFCC.
They do, and the distractor they almost always use is the radiolunate ligament.
The radiolunate ligament?
Right. The radiolunate ligament is a strong, important, volar extrinsic ligament of the wrist. It stabilizes the lunate to the radius volarly, but spatially and embryologically, it sits separate from the ulnar complex. It is definitively not a part of the TFCC.
Okay, time to enforce our memory rules. We will state the 6 components twice, and we will explicitly state the radiolunate trap twice. First, the components. The TFCC consists of the articular disc, the dorsal radiolunnar ligament, the palmar radiolunnar ligament, the meniscus homologue, the ulnolanate ligament, the ulnotricutal ligament, and the ECU subsheath.
Listing those 6 components a second time. The TFCC consists of the articular disc, the dorsal radiolunnar ligament, the palmar radiolunnar ligament, the meniscus homologue, the ulnolanate ligament, the ulnotricutal ligament, and the ECU subsheath.
Now, the trap, stated twice, the radiolunate ligament is not part of the TFCC.
Reinforcing the trap, the radiolunate ligament is not part of the TFCC.
With the anatomy mapped out, let's talk about the biomechanical mechanism. What does this complex actually do when you, say, push yourself up out of a chair?
The central articular disc itself, that avascular triangular piece of fibrocartilage right in the middle of the complex, is the main shock absorber. Biomechanical studies show it carries roughly 20% of the axial load across the wrist joint.
20%, okay.
But here is the critical biomechanical twist that catches people out. Despite bearing a fifth of the body weight passing through the hand, the articular disc has almost no stabilizing function for the joint itself. It is there purely to take vertical weight, not to hold the bones horizontally together.
Wait, I have to challenge the logic of that premise. I mean, in almost every other joint in the body, the structure bearing the axial weight like the meniscus and the knee is highly integral to holding the joint steady. How can the central core of the TFCC take 20% of the load but provide 0 stability?
It comes down to the difference between axial loading and translational stability.
Explain that.
Think of the articular disc like a thick rubber mat. If you press straight down on it, axial loading, it compresses and absorbs force beautifully, but it has very weak peripheral attachments to the ulnar styloid. If you try to slide the radius forward or backward over the ulna, those translational shear forces, that rubber mat just slides with it. It offers no resistance.
I see.
Stability comes from the ligaments wrapping around the disc, not the disc itself.
That distinction makes perfect sense. So if a patient injures this complex, how do you assess it surgically? If you are looking at it through an arthroscope, how do you visually and physically know if the central disc is healthy or torn?
We use the trampoline test during wrist arthroscopy. You insert a blunt metal probe into the joint space and physically press down on the center of the articular disc. If the disc is healthy and its peripheral attachments are intact, it will feel taut, springy, and highly resistant.
Like a real trampoline.
Exactly like pressing down on a tightly strung trampoline. It bounces the probe back. If the TFCC is torn, whether centrally or torn away from its ulnar attachments, it loses all that tension. It will feel floppy.
What does floppy actually feel like to the surgeon? Because a torn ACL feels like a wet mop. What does a torn TFCC feel like against the probe?
It feels like a complete loss of resistance. The probe just sinks passively into the tissue without any elastic rebound. The disc feels like it is floating on the synovial fluid, entirely lacking that tight drum skin tension a healthy complex has. A floppy response equals a positive test. It confirms a significant tear.
And what is the classic mechanism of injury that causes that tear? When a patient ends up with a floppy TFCC, what did they physically do to their arm?
The classic injury mechanism is an axial load applied to a twisted wrist. Physically, this almost always translates to wrist extension combined with forearm pronation.
Extension and pronation.
Right. Think of a patient bracing for a fall. They throw their hand out, palm down. That's pronation. The wrist bends sharply back in extension, and their body weight crashes down through the hand. That twisting compression cleanly shears the fibrocartilage complex.
Rule enforcement time. We need to state the load percentage, the lack of stabilization, and the injury mechanism twice. First, the articular disc carries roughly 20% of the axial load but has almost no stabilizing function, and the classic injury mechanism is wrist extension combined with forearm pronation.
Repeating those biomechanics. The articular disc carries roughly 20% of the axial load but has almost no stabilizing function, and the classic injury mechanism is wrist extension combined with forearm pronation.
If you only remember one thing from this section, remember this. The TFCC comprises 6 components, excluding the radiolunate ligament. Its articular disc bears 20% of the load but provides no stability. A floppy trampoline test indicates a tear and is injured via wrist extension combined with forearm pronation.
We just established that the TFCC's central articular disc provides excellent cushioning but absolutely zero translational stability. This logically forces us to ask the next biomechanical question. What actually stabilizes the distal radioulnar joint, the DRUJ?
Exactly. I mean, if the mat doesn't hold the floorboards together, what does? Let's transition from the cushion to the true stabilizers. What is preventing the radius and ulna from just sliding apart every time you turn a doorknob?
The true primary stabilizers of the DRUJ are the dorsal and palmar radioulnar ligaments. If you recall, these were on our list of TFCC components.
Right, the margins.
Yes. They form the thick, fibrous margins of the complex. They arise deeply from the ulnar fovea and the base of the ulnar styloid, and they fan out to insert broadly on the volar and dorsal edges of the sigmoid notch of the radius.
And how do they function dynamically?
They act in an alternating reciprocal fashion. During supination, turning your palm up, the palmar radioulnar ligament pulls tight to stop the radius from rotating too far backward.
Okay, palm up, palmar's tight.
Exactly. And during pronation, palm down, the dorsal radioulnar ligament pulls tight to prevent it from slipping too far forward. Together, they are the primary restraints to dorsal and palmar translation of the radius on the ulna.
So it's not the central disc, it is strictly those dorsal and palmar radioulnar ligaments. If a patient comes into the clinic and you suspect they've torn those ligaments, how do you test that stability without an MRI?
You use a provocative clinical exam called the piano key test. You have the patient sit with their forearm resting firmly on a table in full pronation, palm down. You place your thumb over the prominent knobby head of the distal ulna on the back of their wrist, and you press down sharply.
And what happens?
In a stable joint, it barely moves. If the radioulnar ligaments are torn, the distal ulna will ballot, meaning it will spring down volarly when you push it and bounce violently back up dorsally when you release it. It looks and feels literally like pressing a piano key.
That is a highly visual sign. But we need to highlight an incredible anatomical illusion here. The way you just described the piano key test, and frankly, the way we all visually perceive the wrist, makes it look like the ulna is the bone that is loose and moving around.
It is a pervasive optical illusion. Clinically, in the exam room, we talk about the ulna translating dorsally or volarly. We physically press the ulna down. But anatomically and biomechanically, the ulna is actually the fixed stationary post of the forearm.
Wait, so the radius is the bone doing all the moving?
Precisely. The proximal ulna is locked into the elbow joint via the rigid hinge of the olecranon. It does not rotate. It is the radius that translates, swings, and rotates completely around the fixed ulna during pronation and supination. So while the ulna seems to be the moving, unstable part when you press on it clinically, the pathology is actually that the radius has lost its tether and is failing to orbit smoothly around its fixed post.
The radius orbits the stationary ulna. It's conceptually brilliant. Okay, let's look at surgical solutions. What if those ligaments are destroyed, the joint is severely arthritic, and you cannot reconstruct the ligaments? You might look at a salvage procedure like a Darrach.
Yes. The Darrach procedure is an end-stage salvage option for a painful, arthritic, or irreversibly unstable DRUJ. It involves the surgical excision of the distal ulna entirely.
Just removing it.
You simply cut the distal few centimeters of the ulna off and remove it, eliminating the painful bone-on-bone articulation of the sigmoid notch.
But removing a chunk of bone from a balanced system has to have mechanical consequences.
It certainly does, and the classic complication of the Darrach procedure is known as dynamic radioulnar convergence. Without the prominent ulnar head acting as a physical spacer to hold the bones apart, the powerful muscles of the forearm pull the remaining ulnar stump forcefully toward the radius.
They just clash together.
Yes. When the patient tries to grip something heavily or rotate their forearm, the radius and the transected ulnar stump physically clash together. This convergence can be quite painful and distressing.
And here is the major exam trap regarding dynamic convergence. The examiners will try to make you link this complication to the patient's functional outcome. What does the severity of that dynamic convergence actually correlate with?
Dynamic radial ulnar convergence correlates only with the physical length of the distal ulna that was surgically excised. It is a purely geometric relationship. The more bone you cut away during the Darrach, the more convergence you get.
What's the trap?
The trap is that they will list a series of functional metrics. You must remember that dynamic convergence does not correlate with patient outcomes. It does not correlate with their grip strength. It does not correlate with their pinch strength. It does not correlate with their range of movement. And it does not correlate with their overall objective risk score.
Wow, okay.
A patient can have terrible convergence on an X-ray, but function beautifully in daily life.
We absolutely need to enforce our rules on these points. They are too highly tested to skip over. We will state the true stabilizers and the Darrach correlation twice. First, the stabilizers. The dorsal and palmar radioulnar ligaments are the primary restraints and true stabilizers of the DRUJ.
Reinforcing the anatomy. The dorsal and palmar radioulnar ligaments are the primary restraints and true stabilizers of the DRUJ.
Next, the Darrach correlation. Dynamic radioulnar convergence correlates only with the length of the distal ulna excised and does not correlate with grip strength, pinch strength, range of movement, or wrist score.
Reinforcing the Darrach trap. Dynamic radioulnar convergence correlates only with the length of the distal ulna excised and does not correlate with grip strength, pinch strength, range of movement, or wrist score.
If you only remember one thing from this section, remember this. The dorsal and palmar radioulnar ligaments stabilize the DRUJ, gross instability is demonstrated by the piano key test, and post-Darrach dynamic convergence correlates only with the length of ulna excised, not with functional strength.
We have mapped the lunate, we have mapped the TFCC, and we have secured the radioulnar joint. It is time for our second major consolidation point.
If you are listening on a run or organizing your study notes, let's do our mid-episode recap number 2. We will rapidly summarize the soft tissues and joint mechanics we just covered. As always, we will state every key list and discriminator twice. Let's start with the TFCC anatomy.
The TFCC components list, stated twice. It includes the articular disc, the dorsal radioulnar ligament, the palmar radioulnar ligament, the meniscus homologue, the ulnar-variance ligament, the ulnar-tricutal ligament, and the ECU subsheath. And importantly, the radiolunate ligament is excluded. Stating again, it includes the articular disc, the dorsal radioulnar ligament, the palmar radioulnar ligament, the meniscus homologue, the ulnar-variance ligament, the ulnar-tricutal ligament, and the ECU subsheath. And importantly, the radiolunate ligament is excluded.
The biomechanics of the disc stated twice. The articular disc carries roughly 20% of the axial load with almost no stabilizing function. A floppy trampoline test indicates a tear, and the injury mechanism is wrist extension combined with forearm pronation. Stating again, the articular disc carries roughly 20% of the axial load with almost no stabilizing function. A floppy trampoline test indicates a tear, and the injury mechanism is wrist extension combined with forearm pronation.
The DRUJ stabilizers list, stated twice. The primary restraints are the dorsal and palmar radioulnar ligaments. Stating again, the primary restraints are the dorsal and palmar radioulnar ligaments.
And finally, the Darrach complication discriminator stated twice. Dynamic radioulnar convergence correlates only with the length of distal ulna excise and does not correlate with grip strength, pinch strength, range of movement, or wrist score. Stating again, dynamic radioulnar convergence correlates only with the length of distal ulna excised and does not correlate with grip strength, pinch strength, range of movement, or wrist score.
Brilliant. We've mastered the carpal bones and the soft tissue padding. Now we must inevitably pivot from the native joint space to the hardware we use to fix it when it shatters. We are moving our focus entirely to the distal radius danger zones.
Let's talk about metal on bone. Distal radius fractures are incredibly common. It's the bread and butter of trauma calls. And in modern practice, we predominantly fix them with volar locking plates. But burying metal deep in the wrist comes with highly specific anatomical risks.
The most prominent and tested risk of volar plating is the iatrogenic rupture of the flexor pollicis longus, or FPL, tendon. This isn't a random occurrence. It happens because of a very specific topographical feature on the radius called the watershed line.
What's the watershed line?
The watershed line is the most prominent distal volar ridge of the radius margin. It acts like a high-tension pulley for the flexor tendons.
So if the surgeon places the plate too far down toward the joint line...
Precisely. If you place your metal plate too distally, so it sits proudly past or directly on top of this watershed line, you have just replaced a smooth, cartilage-covered bone pulley with a hard, sharp titanium edge.
Ouch.
Because the pronator quadratus muscle cannot fully cover plates placed this far distally, the FPL tendon rubs directly against the metal every single time the patient flexes their thumb. Over months, this continuous attrition frays the tendon until it quietly snaps.
So volar plates risk the FPL at the watershed line. As a quick conceptual callback to your other study modules, remember that dorsal issues like placing a dorsal plate or having a fracture spike around Lister's tubercle threaten a completely different thumb tendon, the EPL, or extensor pollicis longus. But for the volar side, the palmar side, the danger zone is all about the FPL.
That is the exact discriminator examiners want to see you recognize. Now, let's explore the biomechanical function of the plates themselves. Not all plates serve the same structural purpose.
Right, like with severe breaks.
Often, you will encounter a discal radius fracture that is heavily comminuted, meaning the metaphyseal bone is shattered into dozens of tiny unusable fragments. If you span a plate across this shattered zone from the solid radial shaft proximally to the solid articular block distally, and there is no cortical contact between those main bone fragments, you are utilizing a concept called bridge plating.
A bridge plate. The civil engineering analogy here is perfect. Think of it literally like a rigid steel bridge spanning a deep, shattered gorge. The sturdy supports of the bridge, the screws, are anchored into the solid cliffs on either side of the gap.
Exactly.
But the bridge itself cannot rely on the shattered rubble at the bottom of the gorge, the comminuted bone, for any structural support. There is no cortical contact. So the bridge plate acts as an extramedullary splint. It has to bear 100% of the load-bearing force until the gorge slowly fills back in with healing callus.
That perfectly isolates the concept. A bridge plate bears the load. It doesn't just share it. And speaking of severe comminution, the presence of shattered bone completely dictates what surgical hardware you cannot use.
What's the rule there?
Let's discuss isolated percutaneous pinning, specifically Capanghi intrafocal pinning, where you use smooth K-wires to joystick and hold fracture fragments. There's a massive absolute contraindication to using pins alone.
I can guess why, but what is the specific contraindication they test?
Volar comminution. If the strong, thick volar cortex of the radius is shattered, the fracture becomes fundamentally unstable. The volar cortex acts as the primary buttress against the flexor forces of the hand, pulling the wrist into collapse.
And pins just aren't enough.
Thin, smooth metal pins simply do not have the mechanical rigidity to buttress against that powerful collapsing force. If you have volar comminution, relying on isolated pinning will inevitably lead to shortening, angulation, and a failed fixation. You cannot rely on pins alone. You absolutely require the rigid support of supplemental volar plating or an external fixator.
Rule enforcement time. We need to state the FPL watershed trap and the volar comminution contraindication twice to ensure it sticks. First, the volar plate trap. Volar plates placed past the watershed line risk flexor pollicis longus, or FPL, tendon rupture.
Reinforcing that crucial danger zone, volar plates placed past the watershed line risk flexor pollicis longus, or FPL, tendon rupture.
Next, the pinning contraindication. Volar comminution is a massive contraindication to isolated percutaneous pinning.
Reinforcing the surgical limit.
Yeah.
Volar comminution is a massive contraindication to isolated percutaneous pinning.
If you only remember one thing from this section, remember this. Volar plates placed past the watershed line will rupture the FPL. A plate spanning a gap with no cortical contact is a bridge plate. And volar comminution is an absolute contraindication to isolated percutaneous pinning.
We have covered the pathology, the soft tissues, and the hardware. And now, the through line brings us to the grand finale. We are going to tie the mechanical physics of the distal radius beautifully back to the very first topic we discussed. Kienböck's disease and ulnar variance. We are going to put numbers to the forces.
The mathematics of the wrist joint. Let's establish the baseline. In a perfectly healthy, uninjured wrist, what are the load-sharing statistics?
In a normal wrist with neutral ulnar variance, meaning the articular surfaces of the distal radius and the distal ulna are exactly level at the joint line, the massive axial load from the hand is distributed predictably.
How does it break down?
Roughly 80% of the load passes directly through the radiocarpal joint into the radius, and 20% passes through the ulnocarpal joint, through the TFCC and into the ulna.
So a healthy baseline is 80% radius, 20% ulna in neutral variance. But what happens to those numbers when we introduce the structural defect we discussed an hour ago?
This is the dramatic shift. If a patient has a markedly negative ulnar variance, meaning they have a pathologically short ulna, let's say minus 2.5 millimeters, the geometry of the joint is fundamentally altered.
Because the support drops away.
Because the ulna has literally backed away from the carpus, it can no longer support its share of the weight. The force distribution radically shifts. It moves to roughly 95% passing through the radius and only a meager 5% passing through the ulna.
This is the absolute light bulb moment. Think about what those numbers physically represent. We're talking about a structural shift of mere millimeters, literally 2.5 millimeters of bone length.
Right.
But mathematically, that tiny geometric shift rewrites the biomechanical destiny of the entire wrist. It shifts 15% more of the entire crushing force of the hand onto the radius. And what sits directly under that new massive focal point of pressure? The radiolunate facet and the lunate bone. This massive 95% overloading of the radial side perfectly explains the pathogenesis, the microfractures, and the shearing forces that cause Kienböck's disease.
Exactly. The mathematics of the load sharing definitively prove the etiology of the dying lunate. The millimeter shift causes the mechanical failure. The geometry dictates the biology.
We have to enforce these vital numbers. We will state the load-sharing statistics twice. In neutral variance, the load is 80% radius and 20% ulna. In markedly negative variance, the load shifts to 95% radius and 5% ulna.
Reinforcing the joint mathematics. In neutral variance, the load is 80% radius and 20% ulna. In markedly negative variance, the load shifts to 95% radius and 5% ulna.
If you only remember one thing from this section, remember this. Neutral variance shares the load 80-20 between the radius and ulna, but negative variance shifts it to a massive 955 distribution, pathologically overloading the lunate.
And with that realization, we have successfully connected the entire ulnar wrist and distal radius. From the ischemic death of the lunate through the intricate ligaments of the TFCC to the hardware pitfalls of surgical fixation, and finally back to the governing biomechanical physics of the joint.
Which means it is time to turn up the heat just a bit. You've listened to the deep dive, you have explored the why and the how in extensive detail. Now it's time to rapidly test the what. It's time for the lightning round. I will give the prompt and you give the precise single-sentence answer you'd use in a VIVA exam. Here we go. Kienböck's disease is AVN of what?
A vascular necrosis of the lunate, intimately linked to negative ulnar variance.
Lichtman stage I diagnostic finding.
Normal plain films, but visible edema on MRI.
The crucial discriminator between Lichtman stage 3 versus 3.
Stage 3 is collapse without scaphoid rotation. Stage 3 is collapse with fixed scaphoid flexion.
The definitive treatment for stage 4 stiff arthritic wrist.
Total wrist arthrodesis.
The early pre-collapse revascularizing procedure for the lunate.
Distal radius core decompression.
Which volar extrinsic ligament is definitively not in the TFCC?
The radiolunate ligament.
What is the load borne by the TFCC articular disc, and does it stabilize?
It bears roughly 20% of the load, but it does not stabilize the joint.
What does a floppy trampoline test on arthroscopy indicate?
A significant TFCC tear.
The classic TFCC mechanism of injury.
Wrist extension combined with forearm pronation.
What are the true primary stabilizers of the DRUJ?
The dorsal and palmar radioulnar ligaments.
The clinical provocative test for DRUJ instability.
The piano key test.
What does post-Darrach dynamic convergence clinically correlate with?
Only the length of the distal ulna excised.
Which tendon is at high risk of rupture with a poorly placed volar plate?
The flexor pollicis longus, or FPL, at the watershed line.
What do you call a plate spanning comminution with no cortical contact?
A bridge plate acting as an extramedullary splint.
What is the absolute contraindication to isolated percutaneous pinning of the radius?
Volar-comminution.
And finally, the neutral load-sharing ratio across the wrist.
Roughly 80% radius, 20% ulna.
Perfect. What a phenomenal journey today. We went from the quiet, ischemic tragedy of the dying lunate in Kienböck's disease, mapped out its staged collapse through the Lichtman ladder, and clearly outlined the surgical progression to save or salvage it. We deconstructed the TFCC cushion, proved that the radioulnar ligaments are what actually hold the DRUJ together, and finally navigated the hardware pitfalls and danger zones of the distal radius.
It is a remarkably dense and unforgiving anatomical zone, But as we've seen today, when you take the time to truly understand the underlying mechanics, the spatial relationships, and the physical flow of force, the pathology doesn't just need to be memorized, it simply falls into place logically.
I want to leave you with one final thought to mull over while you finish your drive, or your chores, or your revision notes. Think back to those load-sharing statistics we just discussed. A tiny 2 millimeter difference in bone length shifts the incredible forces of the human hand so violently that it literally chokes the blood supply out of a neighboring bone. I challenge you to view the wrist not just as a collection of biology, but as an exercise in pure architecture. The delicate millimeter by millimeter balancing act of wrist biomechanics means that almost all surgical failures in this area aren't mysterious failures of biology or healing. Wait, I mean, they are tiny, almost imperceptible miscalculations of geometry.
It is a profound truth in orthopedics. A bone left a millimeter too long, a titanium plate placed just slightly past a bony ridge, a few uncorrected degrees of scaphoid flexion. In the wrist, the geometry always dictates the biology.
Exactly. So keep that rigorous architectural mindset at the forefront as you continue to study. Be sure to mentally replay those Lichtman ladder stages and the ulnar variance load-sharing figures on your next commute. Keep grinding, keep reviewing, and we'll be right here for your next deep dive.